So today I would really like to express my appreciation to Doctors Garth Terry and Cyril D'Souza, who are going to talk to us today about mental health and cannabis. So Dr. Garth Terry is a psychiatrist investigator in the Mental Illness Research, Education, and Clinical Center, or MIRIC, at VA Puget Sound, and assistant professor in the departments of psychiatry and behavioral sciences, as well as radiology at the University of Washington School of Medicine. His areas of research interest are in novel radioligand development and their application in neuropsychiatric conditions, including ones for the CB1 receptor and for clinical studies involving cannabis and cannabinoids. Dr. Cyril D'Souza is professor of psychiatry at the Yale School of Medicine and a staff psychiatrist at the VA Connecticut Healthcare System. He brings over 3 decades of experience at the intersection of clinical care and translational neuroscience. His research program focuses on understanding the acute and chronic effects of various drugs, including psychedelics and cannabinoids, on human behavior, cognition, brain, and function. His research has been continuously supported by NIH, the VA, and private foundations, and of course, he's published extensively in top-tier journals. He's the principal editor of the journal Psychopharmacology and is the inaugural director of the Yale Center for the Science of Cannabis and Cannabinoids, who also do their own webinars and have very interesting meetings that I've been fortunate to be able to attend. So today they're going to pass it off back and forth as part of the presentation. Thank you again, Garth and Cyril. And Garth, I think you are going to kick it off.
Great. Thank you so much for the introduction and for the invitation to speak here this morning. Okay, I'm going to share.
And could I just butt in and just personally welcome both of you as well? Thank you so much for taking the time and doing this.
Oh, thank you. Thank you. Much appreciated. Good to see you. Yeah. Yeah. Great. And I'm going to see if I can also get into a laser pointer. Okay, fantastic. Great. Well, again, thank you for the introduction and the opportunity to present this morning or afternoon to the CMCR. And Dr. D'Souza and I will be doing a little bit of a tag team effort reviewing our recent JAMA Internal Medicine publication on cannabis and mental health. And so I don't have any relevant disclosures, and the opinions presented here today don't represent that of my or Dr. D'Souza's employers. And just a reminder that cannabis is a DEA classified Schedule 1 or perhaps Schedule 3 compound, depending on the circumstances, and we'll comment on that later. So the objectives today are to examine the interaction of cannabis on various psychiatric and mental health conditions, primarily mood disorders, anxiety disorders, post-traumatic stress disorder, or PTSD, and psychotic disorders. And I hope that you'll be able to walk away from today being able to describe cannabis withdrawal symptoms and recognize their potential overlap with comorbid clinical disorders, and then develop a plan for talking to patients about cannabis. And as we conclude today, hopefully we'll have a little bit of time to have a group discussion on that final point. So as an outline of the overall talk, we'll review the changing landscape of cannabis use in cannabis products, the range of THC content that has changed over time, and its variety of modes of consumption, and a point about scheduling. As I mentioned, it's a changing landscape even in the last month on that topic. And then we'll review evidence of cannabis either having beneficial effect or risks related to psychiatric disorders, specifically mood disorders, anxiety disorders, PTSD, psychotic disorders, and we'll cover ADHD and cannabis use disorder and effects on cognition. And what are some of the cannabinoid interactions with mental health medications that clinicians should be aware of, and perhaps some talking points about how to talk to patients about cannabis and mental health. So I want you to imagine a clinical interaction, particularly in a primary care or internal medicine setting, where a physician is going through various medication checks and preventative medication or preventative medicine steps. And towards the end of the appointment, there may be a question of, is there anything else? And the patient may say, oh, I've been feeling really blue and really down lately, just haven't had a lot of interest in things. I'm wondering if I'm depressed. And also I've been really anxious and just don't really know how to manage this anxiety. And the clinician might say something like, well, we could offer you some medications or maybe talk therapy. And the patient may respond to me, well, I've heard about cannabis may be an option for treating depression or anxiety. Is this something that could be helpful for me? Friends have talked about this, and I've seen ads in shops around that have advertisements for cannabis helping anxiety. And the clinician may be familiar with cannabis in certain contexts, like, maybe are they talking about maybe smoking a joint, or is this going to be helpful or is this going to be harmful? Like, where can I get some more information about this and have an informed discussion? And so, to that end, Doctors Kansagara and Dr. D'Souza and Chelsea Ayers, we co-authored a article recently in JAMA Internal Medicine aimed at internists and primary care providers to look at the overlap of cannabis and its effects on mental health, and what primary care and internist providers should be prepared to discuss with their patients. A lot of the information that's in the article was garnered from the Systematic Testing of the Evidence of Marijuana, or STEM project, which has been spearheaded by Dr. Kansagara. And I encourage you to visit it if you haven't already. It's at cannabisevidence.org down below. And I'll have that website multiple times throughout the talk as well. So the article really scraped a lot of the living review and multiple narrative and meta review and systematic analyses that comprise STEM. And there's various infographics, both for patient-facing interactions and for clinicians and researchers on various topics. It's a living review, and it's updated about every 6 to 12 months on each topic, roughly. And it has a nice sort of in-depth and then distilled collection of evidence. And so I'll be highlighting some of the data from that website throughout the talk. So why is it that maybe the patient has expressed interest in cannabis and described that there's a lot of friends who have been talking about cannabis, and it's in part because there's been a dramatic increase in escalation on cannabis use throughout the United States. And as you can see here on this figure, both individuals who use anywhere from daily to just in the past year, there's been a substantial increase since around, this is all normalized to around 2008, since there's been an explosion in access to cannabis throughout the country in various states. And to the point where now cannabis use has overtaken alcohol use in terms of daily or past year use. So this is quite an escalation in the amount of cannabis use in the last 2 decades. Somewhat more pertinent to the overlap of cannabis use and mental health is that in this study in 2024, looking at veterans, the number of veterans who presented to the VA and had diagnosis of cannabis use disorder, the majority of them actually had a comorbid psychiatric disorder. And so as opposed to having cannabis use disorder without a comorbid psychiatric disorder. So the overlap of cannabis use and mental health is particularly noteworthy there. And when we look at a breakdown of the different diagnoses that these veterans had, you can see listed here, the most were with bipolar disorder, followed by psychotic spectrum disorder, depressive disorder, PTSD, or anxiety disorders only. And this is without comorbid disorders, just individuals with individual diagnoses. And so, this study didn't look into whether or not patients were using cannabis to address their mental health symptoms, but I think that primary care providers and psychiatrists should be aware that many their patients with these various disorders may be using cannabis, whether it be recreationally or in order to ameliorate some of their symptoms. As well, and this is a figure taken from our paper, as well, there's an explosion in the types of products and modes of cannabis consumption that's been made accessible to the general public. And it's ranges in potency in terms of the amount of THC that's in each of these products, with dried cannabis flower, and then the pollen or hash, and then concentrates with an escalating amount of THC content, which is sometimes referred to as potency. And then it can come in a variety of modes of consumption, from smoking the dried raw flower to mixed with tobacco or other products, or smoked in a pipe or filtered through water, which would be, a bong or a water pipe, or either vaped as the flower or from the oil concentrate, which can be either done in like an e-cigarette form, or done in a dabbing form, which is a form of heating up a glass apparatus and then applying the resinous substance to it. But when if you visit a cannabis dispensary, you'll see all sorts of other modes of ingestion, from capsules to various kinds of edibles, oils, glycerin or alcohol extracts, lotions, salves, balms, suppositories. If you can imagine a mode of consumption, it's probably been devised. So when we're thinking about cannabis, then it's more than just the plant and the flower, which is displayed here. And also, I'll note that the flower has the highest concentration of THC in the upper parts. And if you see these sort of crystalline-looking structures, those are representative of the trichomes, which is where the oil deposition of the cannabinoids are the highest concentrated, which are then dried and then repackaged. In Oregon and California, I did my residency at UCLA, and these were some pictures taken around the time with permission of the dispensary owner. In Oregon and California, the products are sold sort of semi in bulk like this. In Washington State, every cannabis product has to be individually packaged and labeled with an approximate THC and CBD concentration. And so each of these buds would be in an individual wrapped container, just a kind of point of distinction on the West Coast. And the cannabis could be sold as dried bud and then consumed, but more and more frequently we're seeing cannabis products that are reformulated and repackaged, where the cannabinoids are extracted and then reformulated into peanut butter, baked crackers, cookies, high concentrates, etc., which can also be made more accessible and appealing to more naive customers who may be looking to use cannabis for the first time and may have questions about what is the type of cannabis they should be using, and the mode that would be easiest for them to initiate with. I've mentioned high concentrate cannabis products, and here are some examples in this slide is provided by Dr. D'Souza. And these are very high potent, high THC containing products with about 80 to 90, or I've seen some examples even up to 95% THC. As we'll talk about throughout the hour, the risks associated with the risks and harms of cannabis use seems to be mostly correlated with the amount of THC. And so knowing that patients may have access or maybe utilizing some of these very high concentrate products should be made aware to providers so that they can have an informed discussion about the appropriate type of product. To cut to the chase at the end, my recommendation would be that these products don't really have any sort of symptomatic relief role, and should be avoided for individuals who have mental health conditions. So thinking about how is it that these different kinds of formulations and these modes of use can change the exposure of THC and in the ingestion, we think about two main forms primarily used by patients and consumers. One is by smoking it, and the other is by oral consumption. And THC, when smoked and consumed, like almost any other smoke product, has a very rapid uptake into the lungs and into the bloodstream with the bioavailability that's roughly around 10 to 25%, and peaks within about 3 to 5 and up to about 15 minutes. And with a single ingestion would wash out 90 to 95% within about 3 hours. And so there can be a rapid uptake and then rapid washout. The pros of this approach is that it would allow someone then to easily titrate up to what would be the intended effect, because they'd have a much more rapid feedback between the consumption and then the effect of the THC. The cons, however, is that just like with any substance that can have any kind of a euphoric or addictive potential, drugs that rapidly get into the brain and then also rapidly wash out have a higher likelihood of leading to patterns of addiction. On the other hand, when we look at oral consumption of THC and cannabis products, it has a much slower bioavailability, peaking after about 2 hours, because it takes time for the cannabis product to go into the digestive tract, the GI system, and then all the enzymes to start breaking things down and start to absorb it. And over those 2 hours or so, about 5 to 10% of the product is made bioavailable. But as I mentioned, it takes time for those enzymes to ramp up, right? And as many of the listeners on this call are aware, cannabinoids are very lipophilic, meaning they're fat soluble. And so it's been shown that the pharmacokinetics can really change. If somebody has a fatty meal, it can actually increase the absorption of cannabinoids by 4 to 5 times and dramatically increase the amount of THC exposure in the body during that time. Now, the washout is much slower as well, taking about 4 to 8 hours on average, and the peak is lower than that of the smoked THC. But arguably, there could be potentially even more, area under the curve due to the slow but lower uptake and washout. But as well, something to bear in mind in terms of the pharmacokinetics is that THC, when it is orally absorbed, pretty much all of that is absorbed is going to be going through the portal system into the liver and then metabolized. And there's a metabolite, 11-hydroxy-THC, that has potentially even a higher affinity for the cannabinoid receptors and brain uptake and residence in the brain, so could actually even have a greater clinical effect than THC alone. So effectively, we could be looking at an area under the curve with the change in absorption and the metabolites of something like that. So I refer to the CB1 receptor and where cannabinoids go. This is, again, a figure from our paper with assistance from the artist from JAMA, looking at a description of where cannabinoid type 1 and cannabinoid type 2 receptors are located in the body. And these receptors were named and identified because THC is what bound to them, right? So the cannabinoid products led to the identification of cannabinoid receptors. And as you can see, CB1 receptors are found in multiple areas throughout the body, and in particular in the brain. CB2 receptors, on the other hand, have much lower role in the brain, essentially no expression in the healthy brain. They may have some expression in certain types of cells in the brain during inflammation, but by and large, on a day-to-day basis, their expression is relatively negligible. But we see CB2 receptors on areas of immune cells and in bone marrow and liver and pancreas. CB1 receptors are really found throughout much of the brain, throughout the cortex and the basal ganglia, as well as in the cerebellum and the brainstem. So they're pretty much expressed everywhere, except maybe lowest density in the white matter. But there's potentially even some there as well. So I couldn't help but to put in a slide from some of my prior work where we radio-labeled an antagonist for the CB1 receptor, C11-METPEP, and did whole body imaging in healthy subjects. And although this is looking at radioactivity from the radio tracer, not necessarily CB1 receptors, bear in mind that because we're injecting, you can see here in the left arm, this very lipophilic, sticky radioligand sticking on the veins as it goes into the body, and then goes through high blood flow organs like the lungs and the kidney, but very rapidly starts to accumulate in the brain. And about 10, somewhere between 10 to 15% of all the radioactivity from the study actually accumulated in the brain, which is reflective of the high CB1 receptor density in brain. We also see kind of in the midpoint of the scan that there's some metabolism, but also probably some binding directly in the liver. And you can also make out there's heart and spleen, and then you start to see the axial skeleton, which is reflective of bone marrow. You don't see this on all C11 PET tracers like this, so I think that the bone marrow is probably reflective of, likely reflective of CB1 receptors location. And then at later time points, we can actually see a little bit of a faint area underneath the shoulder, which is probably brown adipose tissue, which is also where CB1 receptors have been reported. Here you see the gallbladder where radioligand has been excreted by the liver and is starting to make its way out of the body. So what are these endocannabinoid system and CB1 receptors doing? This is a figure, a static figure from our paper, which is I'm providing just for some reference, but I'm going to talk through the actions through this animation slide that I've prepared here for a little bit more dynamic live version. So we usually think about in the brain of the two main types of receptors, presynaptic and postsynaptic neurons, and the synapse being the space in between them. And when the presynaptic neuron has some kind of signal that says, triggers the release of neurotransmitters that are stored in vesicles, these vesicles then move to the membrane of the presynaptic neuron and releasing the neurotransmitter. And this could be GABA, glutamate, dopamine, which are the typical ones that are engaged in the system. And then when that neurotransmitter hits the receptor on the postsynaptic neuron, that leads that cell to then propagate, that neuron to propagate whatever that message is going to be. But at the same time, there is a separate and parallel message to enzymes to create on demand these endogenous cannabinoids or endocannabinoids. Here I've displayed anandamide, and the other one we think of as 2-arachidonylglycerol or 2-AG. And this endocannabinoid goes back to the presynaptic CB1 receptor, which then leads to a cascade of events that leads to a retraction of an inhibition of these vesicles from binding to the synaptic membrane and leading to more neurotransmitter release. And so what we have is essentially this feedback system through retrograde neurotransmission, leading to an inhibition of neurotransmitter release. And so we can think about in a system dynamic and network throughout the brain where there's a coordination of neurotransmitter release, that this system might be helpful in kind of regulating the connections throughout the brain and wiring of different networks. Now, these endocannabinoids can get metabolized through fatty acid amide hydrolase or MAG lipase. And then when we think about THC entering the picture, there's all these CB1 receptors. I just had one in that prior cartoon, but there's very high density and there's multiple of them on these presynaptic neurons. And then when THC comes in and binds, it can lead to a downregulation and desensitization of the CB1 receptors. And we have evidence of this occurring in vivo imaging, which we'll show a little bit later. So getting back to thinking about the big picture in our world about cannabis and cannabinoid products and what our patients might be facing, it can really vary from place to place. Right now, cannabis remains illegal on a federal level, but on states, there's been an increasing relaxation of restrictive cannabis laws with medical dispensaries popping up and also access to non-medical uses. And most recently, back in April, 1 month ago, US DOJ moved FDA-approved cannabis drugs or medical or marijuana containing compounds that follow state qualifying medical issued license from Schedule 1 to Schedule 3. but anything that is a non-medical issued product remains on Schedule 1. So this is a dynamically evolving landscape, and this had gotten quite a bit of news, but I think that by and large, the take-home message should still be the patients that it remains a Schedule 1 on a federal level, and that it may vary from state to state, but by and large, I would still consider it Schedule 1. In Washington State, we have a separate medical and non-medical tract, but around 2018, they were basically put on the same system, and so the medical system is functionally not really very active any longer, and it's really the non-medical retail system. On the cannabisevidence.org website, you can go to the subtab policy and find living updates on what are the state-by-state status for cannabis legalization. As you can see here on the West Coast states, Washington, Oregon, and California are all legal for medical and adult use, or retail and non-medical use, as well as medical use. So that brings us to item number 2 of our talk today, which is reviewing the evidence of cannabis and psychiatric disorders. And just to give you the bottom line up front, for mood disorders, we've found through the literature there's no benefit and potentially worse outcomes, particularly with bipolar disorder. With anxiety disorders, there's low certainty anxiolytic effects of cannabidiol and no clear effect with THC on anxiety disorders. With post-traumatic stress disorder, there's no meaningful improvement in PTSD symptoms with cannabis products. In psychotic disorders, there's strong evidence for dose-dependent risk with use. With ADHD, there's no clear benefit. With cannabis use disorder, be aware that about 30% of adults who have used cannabis in the past year may have cannabis use disorder by prevalence. And in terms of cognition, there's clearly an impairment with acute use and possibly with chronic use. And so we'll go over these in a little bit more detail one by one. So on the STEM website, cannabisevidence.org, you can find infographics such as this one. And on each of these, you'll see the condition that's under study, the type of cannabis or cannabis product that was included in the analysis based on how much literature may have been available, the symptoms that may be controlled. So for instance, in depression, there is no association with remission, and in depression, symptoms were worsened following more cannabis use. And then there's usually breakouts for quality of life and functioning, healthcare utilization, and safety. For many of these, there's either no association or no evidence available, given the dearth, especially in depression, the dearth of research that has really been done on that topic. However, as we note in the article, separate from studies of depression, it has been noted that in young adults who use cannabis regularly, there's associated increased risk of suicidality and risk of self-harm. And so we would caution use of cannabis for individuals with depression. Now, in bipolar disorder, although there's low certainty evidence, there has been a demonstration that there's worsened mania and decreased recovery. In a study that really highlights this particular effect, we can see here that in over 2,000 patients with bipolar disorder who have followed for 24 months, individuals who, compared to individuals who never used or had previously used cannabis, current users of cannabis had decreased rates of recovery, decreased remission, and increased chance for recurrence and relapse of mania and symptoms of bipolar disorder. Looking at anxiety disorders, we noted that about 50% of individuals who have a mental health condition and are using cannabis for symptoms of a mental health condition usually report using it to self-treating and addressing anxiety symptoms. And so this is one that should garner quite a bit of interest. Now, the most promising evidence so far is that cannabidiol may reduce some anxiety symptoms. However, the evidence still remains in low certainty. And the dose of CBD that has been used in these studies is in the range of about 150 to 300 or 600 milligrams per day. There's multiple clinical trials that you can find on clinicaltrials.gov looking at cannabidiol for anxiety. So hopefully we'll know more about this in the near future. In terms of THC or THC on anxiety, there's mixed effects have been reported, mixed findings have been reported, and there's very low uncertainty evidence with regard to the evidence. One of the interesting pharmacological effects of THC seems to be that in some individuals may actually have reduced anxiety, but other individuals may have increased anxiety. But almost all individuals with higher doses of THC seem to have worsening anxiety. And so there's kind of a little bit of a conundrum there, and we don't quite know what it is that would predict who's going to respond well to THC for anxiety versus those who don't. So this is an area that really deserves more study. Now, in terms of post-traumatic stress disorder, cannabisevidence.org has quite a bit of information on this topic, and I do recommend for this topic visiting the page for more details. But in general, what's been found is that there's no difference in outcomes of PTSD severity. There had been a small study, I think it was roughly around 10 to 20 individuals who were treated with nabilone. It decreased PTSD-associated nightmares, but when treatment stopped, the nightmares returned. So it was a symptom moderating treatment, but not effectively a treatment or disease-altering treatment. There's been no difference in outcomes of sleep quality, functioning, or mental health difference when looking at the data overall. In general, my approach in thinking about cannabis use in PTSD is that there can be some positive reinforcement for individuals who who have PTSD and use cannabis. As I mentioned, it may reduce nightmares, may help in doing so, may help improve their sleep, and being anticholinergic as well, THC may help with night sweats, and THC has had some potential evidence for helping with pain and individuals to kind of avoid things and kind of forget about their problems for a while. So, patients who have PTSD find this really helpful for their symptoms, and they may continue to use it. However, as we'll mention later with withdrawal symptoms, individuals who have PTSD may experience withdrawal symptoms that are very overlapping with PTSD symptoms. And so when they stop using cannabis, they may feel like, oh, well, the cannabis was helping with this, and now I'm having my PTSD come back, when they may not be recognizing the withdrawal symptoms. And so there can be this perpetuative cycle with cannabis use. There has been a double-blind randomized crossover trial, but in that trial, cannabis did not separate from placebo. I believe that there's more studies that are underway, so hopefully we'll have more data to add to that in the future. And from other observational and human research studies, cannabis use has been associated with more severe PTSD symptoms, less reduction of PTSD symptoms during treatment, like using evidence-based treatment of prolonged exposure. Cannabis has been known to interfere with fear extinction, and so that may be one of the mechanisms by which psychotherapies may be impacted by cannabis use. And there can be a greater severity of trauma intrusion symptoms over time, in increased risk of violence and self-harm amongst those who have PTSD and use cannabis. And so generally, we would say that the quality of evidence of cannabis as beneficial for PTSD remains lacking. And this has been summarized in the clinician brief for PTSD and veterans. It summarizes it very well, I think, in the bottom line. It says there's currently insufficient evidence from clinical trials supporting cannabis to treat PTSD, and some patients may report experiencing short-term symptom relief when using cannabis, but PTSD symptom reduction did not differ between veterans and randomized to cannabis versus placebo, and the long-term effects remain unclear. So moving on, I'm going to throw it to Cyril for a little bit.
Okay, great.
Let me know
Thanks.
when you want me to advance the slides.
Sure, you can advance it. I just want to make sure I make some distinctions between psychotic symptoms, which most of us are familiar with, such as hallucinations, delusions, paranoia, etc., as distinct from from a psychotic disorder, which is much more than just psychotic symptoms and includes some important other symptom domains, including negative symptoms and cognitive deficits. Next, one might think about the relationship between cannabis, cannabinoids, and psychosis as the first being, based on the temporal relationship between the two. One would be where the onset of psychosis occurs soon after exposure and only lasts for the period of intoxication. Next. The next would be that of psychosis occurring soon after exposure, but in this case, it lasts beyond the period of intoxication. And then on the far right would be the emergence of psychosis months, maybe years after the initial use of cannabis. And in this case, the psychosis is recurrent and persistent. And in our current nomenclature, we refer to as schizophrenia. Next. So what is the evidence for the first relationship where psychosis occurs immediately after exposure, but only lasts for the period of intoxication? This is data from a lab study that I did several years ago. Next, the y-axis is time and the x-axis is a very reliable measure of psychosis symptoms called the positive and negative syndrome scale. We gave THC at different doses versus placebo to healthy individuals and recorded symptoms. And these were some of the symptoms that they reported. Couldn't keep track of their thoughts, everything happening at once, everything happening at staccato. Thoughts were fragmented, past, present, and future all seemed to be happening at once. Unusual thoughts. I thought you could read my mind. That's why I didn't answer. I felt as if my mind was nude. I felt I could see into the future. I thought I was God. I thought you were trying to trick me. I think most of us are familiar with paranoia that sometimes people report after using cannabis. So we also recorded this in this study. Next. So in our hands, in this first study, we showed that intravenous THC at doses of 2.5 and 5 milligrams induced transient psychotic symptoms in healthy individuals who had been carefully selected and screened for any obvious risk of psychosis. Since then, next slide, there have been a number of other studies that have shown, like us, like the first study, that shown psychotic symptoms following THC compared to placebo, and these were typically in the large effect size range. Next. I think it would be fair to say that if you put all these studies together, and many of them looked at a number of different outcomes, next, is that there's some overlap between some of the symptoms induced by THC and some of the symptoms that are known to occur in psychosis. Obviously, it's not a complete overlap, and obviously not everyone experiences these kinds of effects, but it's fair to say that some of the effects of acute THC mimic some of the symptoms associated with schizophrenia. Next slide. What about the effects of cannabis in those who already have psychosis? Next. This is a slide from Scholler et al. Showing that in general, there's a greater risk of relapse of psychosis in individuals with psychotic disorders who use cannabis. This was a fairly modest effect size of 0.36. Next. In our hands, we did a laboratory study to answer this very vexing question that I faced as a clinician, that patients were using cannabis to quote unquote medicate symptoms of schizophrenia. So when you do laboratory studies and are able to record symptoms in real time, and you have a placebo control, like this study had, we showed that THC increased symptoms of psychosis in patients with schizophrenia, and it also increased negative symptoms relative to placebo. These were transient increases, And these increases occurred despite the fact that the patients were stable and were taking antipsychotic medications. Next slide. Furthermore, in the same study, laboratory study, where we compared 2 doses of THC to placebo, relative to healthy controls shown on the left, schizophrenia patients performed a lot worse than healthy controls under the influence of THC on a very simple word learning task called the Hopkins Verbal Learning Test. If you look at the red line, triangles and lines, schizophrenia patients were able to recall only 2 out of 12 words while under the influence of THC, suggesting that they are much more vulnerable to the cognitive effects of THC. Next slide. What about individuals who don't have schizophrenia as yet, who are considered at high risk? So these would be individuals who have either a family member with schizophrenia, or they have attenuated symptoms that are predictive of later developing schizophrenia. Shown on your left are clinically high-risk individuals. Shown on your right are healthy controls. This was data collected in Meg Haney's lab, and across 3 outcomes, including paranoia, anxiety, the clinically high-risk individuals reported greater increases just with THC relative to placebo, but there were no differences in the degree of high or euphoria between healthy controls and clinically high risk. So these data would suggest that individuals with a risk for schizophrenia might be more vulnerable to the effects of cannabis. Next slide. So what about the idea that cannabis can induce psychosis, and that psychosis can last for a longer period, longer than the period of intoxication? Next slide. So in this case, it manifests immediately following exposure, lasts beyond the period of intoxication, often stays on for days to weeks. Often recovery is complete, but often people require some kind of clinical intervention. Either they need to be hospitalized. And importantly, it seems like this syndrome recurs with repeated cannabis use. Next slide. This is data from Denmark looking at the rates of cannabis-induced psychosis over time between 1994 and 2015. Next. And what you see here is there's an increase in the incidence of cannabis-induced psychosis in 2006, which seems to parallel, next, the increasing availability of cannabis and the increasing availability of high-potency cannabis. So this parallel would suggest that perhaps the increase in cannabis-induced psychosis may be in part related to the availability of higher potency cannabis and more availability of cannabis. Next slide. What's interesting is that when you look at individuals who have cannabis-induced psychosis, what happens to them in the next few years? Many of them are re-diagnosed with schizophrenia. So what these data would suggest is that if you experience cannabis-induced psychosis, this may be a harbinger of a more chronic recurrent psychotic disorder, which in our current nomenclature we call schizophrenia. Next slide. You can skip this, go ahead. So, and the last is, of course, the relationship between exposure to cannabis weeks or months before and the emergence of a persistent recurrent psychosis, which we call schizophrenia. This is a meta-analysis from a while ago, from 2016. But basically, this shows that there's about a 4-fold increase. More recent studies would suggest that the risk of schizophrenia with cannabis exposure in adolescents is even higher than that. Next slide. This was a study done by Marta DeForti and colleagues across Europe and Brazil, showing that if you used cannabis daily and if you used higher potency cannabis, your risk for schizophrenia for an episode of psychosis was 6 times higher than if you never used cannabis. Now, an important point to keep in mind is that higher potency cannabis in this study was cannabis containing 10% THC. One would argue that 10% THC containing cannabis is pretty weak cannabis in this day and age. So based on that, one would predict that with the higher potency forms of cannabis available, the risk that was identified in the study might actually be higher than sixfold. Next slide. This is yours, Garth, so take it over.
Oh, sure. So, and thinking about what might be the mechanism that confers increased risk for the conversion or increased risk of cannabis and psychotic disorders. This is a very interesting PET study, positron emission tomography study, using a tracer that targets the dopamine D2, D3 receptors, which is where many of the antipsychotics that are clinically used will target. Now, we're looking at THC administration or cannabis administration in dopamine D2, D3 imaging. The results have been very inconsistent, but when looking at the difference between healthy controls versus individuals who have schizophrenia or schizoaffective disorder, or one of their first-degree relatives who are unaffected by a psychotic disorder, but would be considered to be at higher risk than someone in the general population, what we see is the color change here representing the difference between the PET tracer given alone and the PET tracer given again after THC administration, with the difference being the amount of dopamine that is competing with the PET tracer. So what we see is that in healthy controls, there's little to no dopamine that is released in the striatum following THC administration. But in patients with schizophrenia or schizoaffective disorder, there's a robust amount of dopamine release. And then interestingly, unaffected first-degree relatives also have that robust dopamine release, linking potentially THC administration, cannabis use, and excessive dopamine release and regulation.
Quickly, the relationship between ADHD and cannabis. As you know, individuals with ADHD, cannabis is the most commonly used substance. They are more likely to start using cannabis earlier, and they're more likely to develop cannabis use disorder. And a key concern is that cannabis may impair the very same cognitive functions that seem to be already affected in ADHD. One could argue that there's a significant overlap in the cognitive deficits induced by THC acutely, and those very same cognitive deficits that are known to occur in ADHD, including deficits in attention, working memory, executive function, verbal learning and recall, processing speed, and also electrophysiological markers or indices of information processing, including the oddball paradigm, the P300, 40 hertz, auditory steady state driving, and so on and so forth. Next slide. So what is the existing evidence? If you look at self-reports, patients with ADHD will report that cannabis use reduces their hyperactivity, anxiety, and may contribute to improved sleep. But the effects on attention and memory, which are the core cognitive deficits of ADHD, are somewhat mixed. When you look at observational studies, going back, cannabis use may worsen attention, impulsivity, and cognition. And in the only experimental study comparing the combination of THC and CBD in a near one-to-one ratio versus placebo, nabiximols did not improve ADHD symptoms in an experimental design. Next. So what are the possible reasons why individuals with ADHD are using cannabis? Either to self-medicate hyperactivity and anxiety because they are more vulnerable to the rewarding effects of cannabis, or it may be to relieve medication side effects. But that may come at a price, the price being that cannabis may worsen those very same cognitive deficits that they struggle with, and in doing so may impact their academic and work performance, and also make them more vulnerable to the risk of cannabis use disorder.
Which brings us to cannabis use disorder. Thank you for the beautiful segue there. So this was another area that we wanted to make sure that clinicians were aware of. So cannabis use disorder is defined in the DSM-5, which is used for classification of mental health disorders. And the typical use disorder criteria, which are listed here, are also mark cannabis use disorder. About 9% of those who ever use cannabis in their lifetime may have cannabis use disorder, and the risk is higher in those who start in adolescence. When we think about prevalence amongst those in the United States who have used in the past year, it's now about 7% of all adults and about 30% of individuals who have used cannabis in the last year could be diagnosed with cannabis use disorder. They're more likely to be younger, male, and have a history of substance use disorder. And of those who have cannabis use disorder, about 50% are in the moderate to severe category, which is categorized by how many of those symptoms listed at the top of the slide are met in the diagnostic criteria. Some of the drivers for developing cannabis use disorder come again back to the amount of cannabis and
I just
THC.
can I just
Oh,
interrupt? Garth,
sure.
we have just 9 minutes left, so we may want to
Yeah, we'll move ahead a little bit. So I'll just note that the one of the main drivers for cannabis use disorder is the amount of THC. And both Cyril and I have done work in demonstrating that CB1 receptors are both downregulated and then re-regulated during cannabis use and then a cessation. Some of this seems to be related to cannabis withdrawal symptoms, which include many of the overlapping symptoms of psychiatric disorders, depression, irritability, nervousness, anxiety, etc. And that these can occur and seem to peak about 1 to 3 days after cessation and can last up to about a month afterwards, and is likely more common than many clinicians may appreciate. Nearly half of regular cannabis users may experience withdrawal symptoms. The effect of cannabis and THC on cognition has also been demonstrated that acute intoxication is associated with mild to moderate deficits in various types of cognitive processes. Adolescents are more vulnerable, particularly those who have heavy or regular use of cannabis, and can lead to declines in IQ. And then in adults, the cognitive effects are likely to resolve after abstinence. There's been some studies demonstrating that there can be resolution of symptoms after complete abstinence if they've started using as adults for cannabis. And we're going to skip over this. So looking at medications that could have interactions, THC and CBD, like any kind of drug handled by the body, is going to be metabolized by various types of enzymes. The ones that most be aware of is with THC is 2C9 and with CBD 2C19. These have had some reported clinical interactions with medications. In general, because of their THC and CBD are inhibiting these metabolic enzymes, the effect is generally to increase the concentration of these various drugs. Ones to be aware of would be tricyclic antidepressants, given the cardiotoxic potential effects with higher doses and the anticholinergic effect. Buprenorphine, particularly if an individual is stopping cannabis use while they're also trying to address their opioid use disorder, which then could lead to fluctuations of the buprenorphine level and lead them into withdrawal. So I want to make sure we have some time for talking to patients about cannabis use and mental health. What do we recommend that clinicians do? Well, we came up as a group to recommend that they routinely ask and non-judgmentally bring up discussions about cannabis use. Patients, and there's been some research to back this up, patients prefer hearing this information from clinicians, but clinicians might not always feel prepared to discuss it. And as such, patients may end up receiving information from dispensaries and dispensary workers who aren't necessarily medically trained to have such discussions. We hope with this article and with this presentation, now clinicians will have an understanding of some of the benefits and risks around cannabis and THC and be able to have a balanced discussion and evidence-informed discussion with patients. We recommend that clinicians counsel high-risk patients strongly. I'll note what high-risk patients are in the next slide. And focusing on harm reduction in general in individuals with cannabis use who have a mental health diagnosis, given the relative lack of benefit and potential risk of harm. We also recommend avoidance of smoked cannabis, given the cause of bronchitis in individuals who smoke cannabis regularly. And we also recommend the counseling on awareness of cannabis withdrawal as it could overlap with mental health symptoms to be able to distinguish the emergence of those symptoms as potentially related to withdrawal and not to the primary mental health disorder. High-risk populations we've already noted as being young adults, and then particularly those with bipolar disorder and psychotic disorders and substance use. We'd also note those with pregnancy. These are all groups that there have been consistent harms signals shown with cannabis use. So to summarize, the risks seems to outweigh the benefits of the effects at this point, and that would be our take-home message. So with some remaining time, and I'm happy to stay on as long as necessary, we'd like to just have you think about, and maybe people can chime in about when you talk to your patients, how do you talk to them about cannabis and mental health? In those discussions, how do you fill in the current gaps in the evidence? Cyril and I both pointed out we have quite a bit of information and knowledge and research that backs up the connection between cannabis and its effects on mental health, but there's a lot of gaps remaining, particularly around anxiety, where there's a huge demand and need from the patients, but not a lot of evidence. How do you reconcile patients' experience and perceptions against that evidence base or lack of evidence base? And what do you think are priority areas to increase evidence for from the patient perspective or from the clinical perspective? So with this, I'll open it up for discussion and
So thank you so much to both of you. There was a lot of material here. We should have given you 2 hours,